Good evening, everyone. Welcome to our functional forum for July. Welcome to those of you who are on Facebook as well, joining us that way. We're happy to have you all here. Tonight we're going to spend some time talking with you about concussion and learning, rebounding from brain injury with neurotherapy. So we're going to spend the evening really looking at what the research tells us about using neurotherapy to treat concussion and TBI. My name is Fran Beganek. I am a licensed psychologist. I'm co-owner of Bhakti Brain Health Clinic. I will be presenting along with Guy Odishaw, who is my co-owner in the Brain Health Clinic as well. And so we're going to get started here looking at a little bit of introduction. So this is us. This is Bhakti Brain Health Clinic. This is the team that we have that works tirelessly day in and day out to really bring this cutting edge training and treatment to individuals that we serve. And Guy and I, and then we have Adam Dowiak and Kevin Martinez, who are both neurofeedback technicians. We have Heidi Naumann, who's our practice manager, and Ann Beganek, who is our clinic administrator. And so this kind of makes up our team at Bhakti. We consider ourselves a center for excellence. What distinguishes us from other clinics, we believe, is that it's the tools that we use, the training that we do, and the time that we commit to continuing to develop ourselves professionally and learn more about the field that we work in. This is a list of the people who have influenced us along the way, the trainers we've had, the mentors we've had, practitioners whose legacy we follow. You can see there's a long list here of people who have really guided us in terms of what we have learned about how to use neurotherapy to work with individuals, and they continue to teach us about what's happening kind of on the cutting edge of research. We are very grateful for all of these folks. At the clinic, we consider ourselves kind of unique. We do both assessment and training or treatment in the clinic. Most often clinics are specializing in one area or the other. Our assessment process is, we make it unique in that we offer a variety of types of assessment. We have a full assessment that we do oftentimes for people who are coming in with issues having to do with ADHD, concerns about focus, that sort of thing. We have cognitive behavioral assessments that we do. We do brain function assessments. That's the neuroimaging that we do. We'll spend a little bit more time talking about that tonight because that's much more relevant to traumatic brain injury. We also include a biological assessment component. That's genetic testing that we do. So all of those are part of what we may do as we are assessing an individual who comes in. What we believe in the clinic is that thorough assessment leads to a more refined diagnostic, which then leads to more efficacious treatment. So when we are working with people who have concussion and traumatic brain injury, the assessment that we typically will do is the neuroimaging. That includes two types of testing. We do a quantitative EEG, that's the QEEG. That consists of us recording data, brainwave data, while the brain is in a passive state, and then analyzing that to take a look at what's happening in terms of brain functioning at that brainwave level. And then we do something called an event-related potential. This allows us to record and then analyze brainwave activity in a more active state. And that the two of these combined give us a really thorough piece of data that we can look at and then analyze to get as much information as we can about where there may be dysregulation in the brain that could be creating impairment for the individual. So we are spending some time this evening talking about concussion, and so we just have a list here of symptoms that tend to show up for individuals who have post-concussion syndrome. So you can read the list here. I'm not going to read all of them, but these are many symptoms, and not everybody will have all of these. Some people will have a mixture of them. Some have just one or two that are pretty significant, and they're experiencing a lot of distress from them. So probably the important takeaway from this slide is that a brain injury does not necessarily look the same for every individual, and those symptoms can really vary a lot. They also, the kind of common denominator about these symptoms is they are typically pretty impairing for the individual. So when we start to look at EEG, we've got this study up here that Noor put out. He's from UCLA, and it's really highlighting this idea that like EEG, when we use EEG to assess for TBI, that oftentimes we don't find what we think we're going to find. And so sometimes somebody's EEG can look normal after an injury, and that just doesn't necessarily mean that there isn't a TBI present. It's just that sometimes we're not picking it up. And conversely, an abnormal EEG is not necessarily proof that there's some kind of organic basis for what the person is coming in, the complaint that they're having. So just kind of important to keep this in mind, kind of that idea that not like we're not always going to see what it is that that one might assume we would see as we start to look into the EEG.
All right, thank you, Fran. So I'm just going to step back just to say a little bit more on the imaging. This is a lot of conversation in the world of TBI, is being able to image what's happened. And whether you're doing an MRI or even a high resolution, like a diffusion, tensor MRI, or a high resolution PET scan, these type of anatomical imaging are not going to show a concussion. They would be able to show if there was to the level of tissue damage. So if there's actually damage to the tissue of the brain, so pretty macro level damage, that would show up in an MRI or in a CAT scan or in a PET scan. But the level we're talking about, where it's an injury to the function of the brain, that's the challenge with imaging. Is traditional imaging is looking at the structure of the brain. When we go to EEG, we're taking a look at the function of the brain, but we don't have a way to tell the difference necessarily between a decrease in function due to a concussion over against any of the other causes that might lead to. So we can see dysregulation, we just can't necessarily say that that dysregulation came from a concussion. So this is a challenge across any imaging field where we're trying to use imaging as a primary assessment for concussion. We really need a full clinical analysis to look at the data across multiple domains, and even then, it's going to be it looks like you have a concussion type of an answer. So it is one of the most common conversations that we have in the clinic when people are coming to us with a TBI. So this image is kind of standard, kind of coup, contra coup idea of a concussion. And it's not that it isn't true, it's just incredibly limited when we think of both this idea of the kind of forward, backwards, the brain slides forward and strikes the skull, and then comes backwards and strikes the skull on the other side. And again, that happens, but in no way is it appreciating what's happening in the inside of the brain. And it also has kind of made this idea of the brain as kind of somewhat of a solid object, when really it's much more like Jell-O than it is like wood. And so that motion, as we're going to see in a brief video coming up here, there's what is happening to this kind of gelatinous structure of the brain when we have an impact in the case of a potential concussion.
Give you a sense of what might be happening concussion. I want to show you the video.
How is the volume here?
When you type into Google, what is a concussion? The CDC website comes up, and this video essentially tells the whole story. What you see is the head moves forward, the brain lags behind, then the brain catches up and smashes into the skull. It rebounds off the skull and then proceeds to run into the other side of the skull. And what you'll notice is highlighted in this video from the CDC, which I'll note was funded by the NFL, is that the outer surfaces of the brain, where it was to have smashed through the skull, looks like it's been damaged or injured. So it's on the outer surface of the brain. And what I'd like to do with this video is to tell you that there are some aspects that are probably right, indicative of what the scientists think happens in concussion, but there's probably more that's wrong with this video. So one thing I do agree with, and I think most experts would, is that the brain does have this dynamics. It does lag behind the skull and then catch up and move back and forth and oscillate. That we think is true. However, the amount of motion you see in the brain in this video is probably not right at all. There's very little room in the cranial vault, only a few millimeters, and it's filled entirely with cerebral spinal fluid, which acts as a protective layer. And so the brain as a whole probably moves very little inside the skull. The other problem with this video is that the brain is shown as a kind of rigid whole as it moves around, and that's not true either. Your brain is one of the softest substances in your body, and you can think of it kind of like jello. So as your head is moving back and forth, your brain is twisting and turning and contorting, and the tissue is getting stretched. And so most experts, I think, would agree that concussion is not likely to be something that's happening on this outer surface of the brain, but rather it's something that's much deeper towards the center of the brain. Now, the way that we're approaching this problem to try to understand the mechanism of concussion and to figure out if we can prevent it is we are using a device like this. It's a mouthguard. It has sensors in it that are essentially the same that are in your cell phone: accelerometers, gyroscopes, and when someone is struck in the head, it can tell you how their head moved at 1,000 samples per second. The principle behind the mouthguard is this. It fits onto your teeth. Your teeth are one of the hardest substances in your body, so it rigidly couples to your skull and gives you the most precise possible measurement of how the skull moves. People have tried other approaches with helmets. We've looked at other sensors that go on your skin, and they all simply move around too much. And so we found that this is the only reliable way to take a good measurement. So now that we've got this device, we can go beyond studying cadavers, because you can only learn so much about concussion from studying a cadaver. And we want to learn and study live humans. So where can we find a group of willing volunteers to go out and smash their heads into each other on a regular basis and sustain concussion? Well, I was one of them. And it's your local friendly Stanford football team. So this is our laboratory. And I wanted to show you the first concussion we measured with this device. One of the things that I should point out is the device has this gyroscope in it, and that allows you to measure the rotation of the head. Most experts think that that's the critical factor that might start to tell us what is happening in concussion. So please watch this video. So when you look at just the film here, pretty much the only thing you can see is he got hit really hard and he was hurt. But when we extract the data out of the mouthguard that he was wearing, we can see much more detail, much richer information. And one of the things that we noticed here is that he was struck in the lower left side of his face mask. And so that did something. First, it was a little counterintuitive. His head did not move to the right. In fact, it rotated first to the left. Then as the neck began to compress, the force of the blow caused it to whip back to the right. So this left-right motion was sort of a whiplash type phenomenon, and then we think that is probably what led to the brain injury. Now this device is only limited in such that it can measure the skull motion, but what we really want to know is what's happening inside the brain. So we collaborate with spine collagens group in Sweden, they've developed a finite element model of the brain. And so this is a simulation using the data from our mouthguard from the injury I just showed you. And what you see is the brain, this is a cross-section right in the front, of the brain twisting and contorting, as I mentioned. So you can see this doesn't look a lot like the CDC video. Now the colors that you're looking at are how much the brain tissue is being stretched. And so the red is 50%. That means the brain has been stretched to 50% its original length of tissue in that particular area. And the main thing I want to draw your attention to is this red spot. So the red spot is very close to the center of the brain. And relatively speaking, you don't see a lot of colors like that on the exterior surface as the CDC video showed. Now to explain a little more detail about how we think concussion might be happening, one thing I should mention is that we and others have observed that a concussion is more likely when you're struck and your head rotates in this direction. This is more common in sports like football, but this seems to be more dangerous. So what might be happening there? Well, one thing that you'll notice in the human brain that is different than other animals is we have these two very large lobes. We have the right brain and the left brain. And the key thing to notice in this figure here is that right down the center of the right brain and the left brain, there's a large fissure that goes deep into the brain. And in that fissure, which you can't see in this image, you'll have to trust me, there is a fibrous sheet of tissue. It's called a falx. And it runs from the front of your head all the way to the back of your head. And it's quite stiff. And so what that allows for is when you're struck and your head rotates in this left-right direction, forces can rapidly transmit right down to the center of your brain. Now what's there at the bottom of this fissure? It's the wiring of your brain. And in fact, this red bundle here at the bottom of that fissure is the single largest fiber bundle that is the wiring that connects the right and left sides of your brain. It's called the corpus callosum. And we think that this might be one of the most common mechanisms of concussion. And that as the forces move down, they strike the corpus callosum, it causes a dissociation between your right and your left brain and could explain some of the symptoms of concussion. This finding is also consistent of what we've seen in this brain disease that I mentioned, chronic traumatic encephalopathy. So this is an image of a middle-aged ex-professional football player. And the thing that I want to point out is if you look at the corpus callosum, and I'll page back here so you can see the size of normal corpus callosum and the size of the person here who has chronic traumatic encephalopathy, it is greatly atrophied. And the same goes for all of the space in the ventricles. These ventricles are much larger. And so all of this tissue near the center of the brain has died off over time. So what we're learning is indeed consistent.
Okay, so a lot of information there. Main thing, though, is that a concussion is a lot more than affecting the surface of the brain. That we can expect to have, or potentially have, diffuse axonal injuries anywhere throughout the brain, depending on the force that went into the body, because at the time of the concussion, rotation, angle, and why concussions are very different across one concussion to another, is how does that brain get contorted, and where will we see strain injuries in the tissue that result in different kinds of functional changes. So this image is really just about that we do need to keep into consideration that the outside of the brain, more of the cortex, the covering, is going to be affected as the brain moves. It's both potentially going to come in a forceful contact with the skull, but also there are tissue connections. There's dura and arachnoid tissues, there's ligaments holding the brain in place, and so that's going to cause the brain to kind of scrape along the inside of the skull, and so you can get damage up on the surface. But then also we want to look inside, and variations on what we were just seeing in that video. These are diffuser tension fiber tracts, and these tracts can become, in a sense, sprained. The same way you might sprain a ligament. If you twist your knee, you could sprain a fiber tract and then develop a dysregulation in how those neurons fire, and therefore change the pathways of communication in the brain as that happens. So we want to talk a little bit, we're going to spend a moment on a bit of the physiology that's happening in traumatic brain injury. So we've got a rapid change in calcium, potassium, sodium. So all of the chemicals associated with transmission of an action potential in neurons. And we get sudden changes of these chemicals moving outside the nerve, inside the nerve. We have more in the extracellular tissue. We have more in the intracellular space. And that changes the ability of the neurons to fire. It can lower their the action potential so that they fire too easily. It can raise the activation level so they take more stimulus to fire. So this immediate change, and then that can lead into inflammation, which can then stretch this out over a longer period of time. It could be days, it could be weeks, it could be years when we get into chronic inflammation. So this shift at a biochemical level is an important part of the cascade of a concussion. It kind of underpins what we look at in the clinic when we're looking at electrical activity. We're asking ourselves when we're looking at electrical activity through EEG, what changes might be happening at a chemical level to produce this signature. But we spend most of our time concerned about what's happening in the neurons themselves and how bundles of neurons are talking to other bundles of neurons in the side of neurofeedback. On the neurostimulation side, we can engage the biochemistry a little bit more and approach what might be happening in a post-concussion syndrome at a chemical level versus just a brainwave level in neurofeedback. So it gives us a couple of tools to address a couple of the changes that can happen. So we're going to take a moment here and just to learn a little bit more about what's happening in the biochemistry at the level of the neuron.
The sodium-potassium pump is a protein pump found in the cell membrane of all animal cells. Its main function is to transport sodium ions out of the cell and potassium ions into the cell. This serves a number of purposes, but is critically important to the function of neurons as it helps to maintain a higher concentration of sodium ions outside the cell and a higher concentration of potassium ions inside the cell. Preserving these differences in ion concentrations helps to stabilize the cell's membrane potential. This is critical for the neuron to be able to fire an action potential, which is the basis of the electrical signaling of neurons. The sodium-potassium pump is a large membrane-associated enzyme that uses the energy of adenosine triphosphate, or ATP, to transport sodium and potassium ions across the cell membrane. All of the details of how this is achieved are not yet fully clear, but the general process involves the binding of ATP to the pump, which promotes the binding of 3 sodium ions and the release of 2 previously bound potassium ions. ATP is broken down and transfers a chemical group known as a phosphate group to the pump, which prompts the pump to undergo a conformational change, or a change in its shape. This causes the bound sodium ions to be released into the extracellular fluid. At the same time, the pump binds 2 potassium ions, which also prompts another conformational change that returns the pump to its previous configuration, and the cycle begins again. Each cycle of the pump causes 3 sodium ions to move out of the cell and 2 potassium ions to move into the cell. Because there is one more positive charge leaving the cell than entering, there is a net loss of positive ions, which makes the resting membrane potential of the cell slightly more negative.
Okay, so a little dip into biochemistry. And so again, you'll see a couple of things in there that are relative to what we do in neuromodulation, neurostimulation. And so that is the resting membrane potential and the impact on ATP production, so cell energy. So we're going to touch on both of those as we move forward here. So again, another effect in a potential effect in the TBI is effect on glutamate, and glutamate's effect on the local cell milieu, affecting the sodium-potassium pump, and we're changing the resting membrane potential, we're changing the production of ATP, cell energy, mitochondria. So we've kind of got this stepping down effect that is spreading out across multiple systems. So we have neurons impacted at the very least at the level of the action potential, but now that's starting to bleed into effects on mitochondrial activity and energy production. Energy production is going to affect a number of things, one of which is being healing. If the body doesn't have the energy to regenerate and to do the cleanup work, then you're going to get a suboptimal healing. So valuable to have an early intervention around energy production and inflammation. So we continue the cascade. We get into impacts on oxygen because of what's happening in both the resting membrane potential, in the energy production. So we're not driving our processes. So glucose metabolism is going to go down, circulation is going to go down, and that's going to drive the impact on our mitochondria even more. So we think of mitochondria as the energy production of the cell, but that idea is shifting as more and more research is showing us that likely the primary impact of mitochondria, function of mitochondria, are cell-to-cell signaling. So they form a network. And if you look into some of the research of what happens with mitochondria, find that they're quite fascinating, intelligent cells. They can merge together, they can create physical chains to create a kind of a physical network, but they can also communicate electrically in larger networks. And we see that in neuroimaging studies using EEG, that there's electrical activity happening at the mitochondrial level in advance of a wave of neuron action potentials. So we know they're playing an important role in information communication and in energy production. So when our mitochondria are negatively affected, it affects us in two places. So we'll talk a little bit in a moment about how do we address that through neurostimulation. So the other aspect is if our mitochondria become unhealthy enough, it can lead to apoptosis and cell death. So we can actually lose mitochondria. And then that we only, you're born with so many mitochondria. It's not that it's impossible to get more back, but it is very difficult, and particularly very difficult in the brain. Easier in the body because you can exercise. If you stress your muscles, you can kind of force your body to produce more mitochondria. But if you're tucking in the brain, that's much more challenging. So this is, again, it can be a devastating part of a traumatic brain injury, and including in that stroke. But right now we're talking about kind of traumatic brain injury, but a stroke leads to this very same cascade of events. So one of the things in neurophysiology that we see is this thing what we call blue brain. And the primary explanation for blue brain is decreased voltage. And there's a couple of ways you can get into a state of having kind of lower than anticipated or lower than neurotypical voltage in the brain. And this cascade that I just described is one way for that to happen. If we have changed the resting membrane potential of neurons, that can make neurons harder to get them to fire so that we can have some dropout of neurons there. If we're lowering the blood flow, oxygen, glucose, so that's going to be the neurons aren't going to have the energy, the means to produce energy, and then they're not going to have the ATP because of the mitochondria. So we have a number of things happening that can produce this low voltage. There are some other things, so a change in the thalamic cortical loop can cause a timing issue, but that's a little bit more of a mechanical than a physiological change, but can also come from a traumatic brain injury, can have a thalamic dysrhythmia. So the other side of this is neural inflammation. And neural inflammation can come from a number of factors. It can be, again, if we have apoptosis, and so we have constituents of dead and dying cells, that'll activate the immune system. That can turn into, if it's a short-lived, a healthy inflammatory response, the immune system. But if that continues and becomes chronic inflammation, then that's an unhealthy inflammatory response. So it can be from simple, kind of biological toxins, catabolites from the injury. It can be blood getting into spaces that it shouldn't be in. Blood should be in the vascular, not in the extravascular space. That can lead to inflammation. The injury to the tissue itself can generate an inflammatory response. So a number of ways in which we can get inflammation, neuroinflammation in the brain, and inflammation itself can become its own cause of dysregulation and loss of function and change in behavior. So it's a clinical finding that we want to address. So here's an example of an EEG or QEEG map. We're looking at what we call the 1 Hertz bins. So each frequency across the whole brain, and you can see they're all lit up red. And they shouldn't be. In this system, they should be gray, which would be equal to the normative database. This is 3 or more standard deviations, excess activity. So quite likely what we're looking at here is neural inflammation. We don't know that as a fact. There really isn't any way to know that as a fact. You can't do a blood test, you can't do an imaging. Everything is just an approximation that says this might be inflammation. EEG has its way of showing it. This is an example. And this is taken from a person who relatively recently had a stroke. And so we might anticipate seeing neural inflammation in somebody who had a significant stroke. So our mantra, we don't treat symptoms, we treat dysregulation. So this goes in both ways in terms of what I've just presented. So we can have symptoms in the sense of change in personality, loss of cognitive function, people's memory starts to slip, word finding, aphasia. There can be a number of cognitive symptoms that come up. Often with TBI, there's personality changes, so that would go on the list. But it can be things like an impact on a person's gait or physical coordination. That can show up on the list as a symptom. So long list of symptoms, and then there's also the physiology side. So I talked about the change of sodium, potassium, calcium. So where we come in, where we spend most of our time is in the middle of those two spaces. We don't really think so much about behavior, and we don't think about biochemistry. We think about neurophysiology and what's happening in the brain waves, the brain talking to itself. So what we refer to as dysregulation. That's where primarily neurofeedback and to some degree neurostim come to bear on regulating dysregulation. So here you see some of the forms that we use in the clinic. We'll get into that in more detail. So here's an example. I'm not going to read, and I won't make you read all of the text up there, but this is a professional athlete who suffered a traumatic brain injury, and they used photobiomodulation as a treatment. And we see they had very positive outcome from this trial of infrared light therapy. And one of the bonuses of infrared light is it's going to go after a couple of the top things that I had talked about earlier. It's going to go after energy production. So one of its number one benefits is it increases ATP production in the mitochondria. It helps improve mitochondrial function. So we have more ATP, more energy, but then also we're going to have better cell-to-cell communication. So we're going to get both sides improvement on the mitochondria. But also, near-infrared light has an impact on inflammation. So it lowers the inflammatory cycle kind of at the cytochrome C interface. And so we get a way to lower neural inflammation without having to use a toxic substance to try and do that. It's also challenging to get an anti-inflammatory across the blood-brain barrier. So reducing neural inflammation with medication it's very challenging. There's very few medications that fit well into this space. And then there's the effect of those when we put it into the brain. So it's a challenging place from a pharmaceutical standpoint. Near-infrared light becomes a great way to address neural inflammation while being overall positive impact on the brain. So here you can see one of the devices we use, photobiomodulation helmet. and this would be the type of a device a person might use at home, post-concussion, to begin the healing process. And really, we can pick somebody up anywhere in that. It could have been 10 years ago. There's still cleanup work to be done. It could have happened 3 weeks ago, and that's perfectly good time to start doing it. So it's a safe, gentle, effective approach to a number of the components of a TBI. So here's one of my favorite cases that I worked on. Lovely person and a great outcome. So everything about it really, is a positive, other than the fact that we had to do it at all. I'm sure she would have appreciated skipping 40 years of chronic depression. What I'm happy about is we got her to a place that really starts to look like resolution after all of that time. So she had done all the standard of care. She had done decades of standard of care, but hadn't given up, which was great. She approached us for neurofeedback to address the chronic depression. So we did our standard intake, QEEG, ERP, all of the verbal intakes that we do. One of the things that showed up, and so in this image we can just see we have kind of the classic blue brain, right, that we saw earlier. She presented with that. And we'll just jump here. So this is one of the things that came out of her report. It's one of the metrics that we often run. And this is kind of saying to us there's a 99.9% chance that she has a TBI, but there was no report of TBI. And so we go through all of the questions, are you sure? Nope, nothing, okay. We move on, we proceed as if what we're working with is really a depression as our not only primary symptom, but primary way of interpreting the data. So we move forward with our usual treatment for that. Somewhere along the line though, we're just not seeing the change that we think we should be seeing. So kind of dip back into the data, and that takes me then back to this report, and we're like, are you sure? So Fran really put it to her, took her through just a series of questions, and finally what emerged was there was an injury. She had fallen while skating and had a serious enough injury that she had to be taken to the hospital. But at that time, in that place, there was no discussion of a concussion. It was never mentioned. There was no treatment for it. It was just, you fell, you're fine, move on. And it wasn't long after that her narrative reports starting to have the changes that eventually would be diagnosed as a chronic depression and treatment of that chronic depression. So from our side, we thought, probably untreated traumatic brain injury. So now we're treating that injury, something like 40 years later. So you might wonder, how effective could it be? And what we found, once we had this as kind of our clinical perspective, so here what you're seeing is her doing the 19-channel Loretta neurofeedback when we were still kind of thinking more along the concussion line. And so we're going to see a little bit of kind of the behind the scenes. And then we're going to go into the main findings. So this is her EEG. As she's training, kind of see various brain metrics. But this was the main area where when we started to look at her autonomic nervous system, that we kind of alarm bells went off. So some of the things we're looking at here is we've switched the paradigm up. So she's training on neurofeedback, on biofeedback, and I'm watching neurofeedback. Usually it's the other way around. We're watching their biometrics while they're training their brain. In this case, now she's training her autonomic nervous system, and I'm monitoring what's happening in her brain as that's going along. And it was once we started doing the biofeedback that she started to report changes. So here we are, session 2. So a couple things to look at is heart rate variability. So this is her heart rate variability. It's actually quite high. If you were to look at that number in our system, the way our metrics look, she's up in the Olympic athlete category, but she is not an Olympic athlete. So that right away was questionable to me. Like, why is that so high? Next thing, we had to issue her temperature. She was chronically cold. So low peripheral circulation, you can see that over here in peripheral circulation is very low. That should be up around 30 as kind of a normative number. Her spectrum right here in terms of how her heart is beating and the rhythmicity of her interbeat intervals. You can see her spectrum has got a lot of texture to it. We don't want to see that. We'd actually like to see one concentrated peak in the middle here. Another thing you'll notice is over here, her actual heart rate, she tends to be up between 85 and 105, someplace in that zone. So a high heartbeat for somebody who's sitting still, low peripheral circulation. We're still seeing, even here in session 3, a higher heart rate variability than we would anticipate for somebody her age and overall condition. So now we're into session 4. We're starting to see a couple of positive changes. So one, we're getting a heart rate variability that is much more normative for who she is as a person. So that's a great change. You're going to start to see coherence start to come online, and that is also a really important change. You'll notice her temperature now. Before, she was hanging out in the 70s, and now we got her up into the 90s, which again is where we would anticipate somebody in a slightly warm room being. And then also we see her blood volume pulse. So here we are into session 5. Her blood volume pulse is now getting up. So that's how much blood, the volume of blood moving through the periphery of the body is up significantly. You could see her EEG looks much cleaner, so this is a plethysmograph, not a true EKG, but it's a much smoother. We can see the spectrum is starting to sort itself out. We don't see the multiple peaks distributed, and in particular up in the high frequency, so that's great. Session 6, so you'll notice here where coherence is starting to spend time up at the top of the meter, whereas before it was below 0, and now we're starting to get up to 50, 90% coherence. This means it's a measure of how well the cardiac rhythm follows the respiratory rhythm. So this is a measure of autonomic balance. When we inhale, our heart rate should increase, and when we exhale, our heart rate should decrease. And that should be just a natural mechanism wired that way. Her system was actually anti-correlated, where when she would inhale, her heart would decrease, and when she exhaled, her heart rate would increase. So it's the complete opposite of what we wanted. So across all of her metrics, you were seeing really dramatic improvement. So again, a heart rate that it's odd to want a heart rate variability to come down, but we really needed hers to normalize. Temperature is good. Blood volume pulse is good, and you see the spectrum is really starting to normalize with just a couple of peaks coming in. And here we are. This is the last session that I recorded. She ended treatment shortly after this. And you can see very nicely the green trace and the red trace are in sync with one another. And that's, again, telling us that following effect is quite strong, because she's not on a breath pacer here. So this is, despite pacing her or not pacing her breathing, her heart, cardiac rhythm and respiratory rhythm are syncing with each other, which again, that takes a pretty healthy system for those two to sync up if you're not pacing your breathing. Right? So overall, a really amazing change in her autonomic nervous system. And what we found, what she was reporting to us as these changes were happening over a series of sessions, was a change in her symptoms of her depression. Work became easier, relationships at work, which she historically avoided, she started to engage in relationships at work, so work became less stressful. Instead of coming home at the end of the day and just kind of collapsing on the couch and not wanting to do anything and knowing she should exercise, knowing she should make a good meal, but just not having the energy, not having the motivation to do it, And now she would go home and she'd actually feel like doing something with her day. So she started to become more social. She started to exercise. She started to cook for herself on a regular basis. So many dimensions of her life started to change. And that was all about regulating her autonomic nervous system. And so one of the things we know about TBI is brain injuries often have an impact down into the brain stem and into the autonomic nervous system. And it too often gets missed. And as a client, she was one of the other additional challenges besides the denial of a head injury was she had a wearable that tracked HRV. Well, as we saw in these early videos, her HRV was stellar. So when I would ask her about this, she would be like, no, my HRV is great. I've been tracking it for years. It's fine. We don't need to do it. That delayed bringing measuring the autonomics into care because she reported having really strong HRV. But again, once we wired it up and we saw the data and we saw how she was getting good HRV, that made all the difference in the world. Her heart was largely, it's overly dramatic to say out of control, but there was not a good control mechanism on her heart. So it was swinging wildly between fast and slow, fast and slow, fast and slow, and not connected to homeostasis. It wasn't changing speed to regulate physiological activity. It was just kind of changing speed on its own. So one of the things we corrected was to bring the regulator of that heart back into line so that her heart rate changed as a measure of homeostasis and self-regulation, which was one of the key missing pieces for her. Okay, so my next one, again, a fascinating case study for me for a number of reasons. One, I was early in my practice of neurophysiology, but also this was a client that I had seen multiple times over the years, more on the orthopedic side, because one of his complaints was chronic pain, orthopedic pain from an accident. So at age 13, he went over the handlebars of the bike, landed on his face, had many maxillofacial fractures, lost some teeth, had to have some reconstructive surgery. And this started a process for him, which just continued until he went through a full course, a really extended course of neurotherapy, and radically transformed his life. But prior to that, from that accident forward, he just slowly more and more disengaged from life until what he did day to day was basically spend time in his bedroom in the dark, playing video games, come out, get something to eat, go back in. That was his life. For years, it was that. He had fantastic parents who tried everything to get him the help he needed. They spared no expense. They traveled all over the world, taking him to specialists. Anybody they thought could help, they found a way to make it happen. So they really put all resources in, and all the way along the way, they would just get little positive changes, enough to remain hopeful, but nothing that really changed the course of his life. So again, I had been treating him all along with craniosacral therapy and other modalities for his pain, and so I watched both the initial injury and his descent into isolation and depression. But then I also, just by grace, got to bear witness to him kind of coming back. And so as we went through, and we were probably close to 40 sessions in before there was anything noticeable. And this was one of the challenges, was because, the family's like, come on, guy, you said 20 to 40 sessions. We're at 38 sessions and we're not seeing anything. So one of the first things we noticed was changes in his posture. So just how he sat in the chair in the waiting room, how he walked back to the treatment room. Those were my first indications that I think something is changing. All right, so this is deep change in the brain stem. And to be able to get change that deep in the system from neurofeedback is pretty profound. But to see his brain changing from the brain stem upwards. So we saw that, just kind of a continuation kind of postural change. And then the next big thing for me is a sign that something was changing was we're sitting in the treatment room and he's sitting next to me doing his neurofeedback, and he turned and looked me right in the face and made a joke. So here's a kid that I've known for maybe 7 years who could barely look me in the eye, and an answer to any question was just a grunt. Right? This was how I knew him for all of the time that I knew him. And so for him to turn and look me straight in the eye and make a joke, I just, we stopped the session and celebrated as I turned in and said, "Do you know what you just did?" So this is now a sign okay, things were beyond just postural changes in gait. We have actual changes at the level of personality. Parents started to report that they were seeing positive changes. So we continued on. We probably did something in the neighborhood of 80 sessions. And so we should take a look. So here again, if we look back to some of our information, this is some of his Loretta imaging. So we have the neural inflammation, kind of whole brain, red. And in particular for him, not only was there this kind of excess activity, his excess was all in slow wave, which is, again, pretty classic for a concussion. So the increased delta, mainly, increased theta somewhat for him. And here we see, if you look at the bottom graph on the side, so if you look here, what we should see down here is kind of a reflection of what we have here, where it looks like we've got kind of a nice peak alpha running a little bit fast, but when we do a statistical analysis on it, we see that actually that isn't the case. We have a much more distributed, so again, there's a sign, there was certainly more of a thalamic cortical dysrhythmia, so the timing mechanism in the brain was off, and it was all running this combination of too slow and too fast. Right, so the brain was just out of sync with itself across many, many, many metrics. And as we brought all of that back into harmony, what we saw was a restoration of function. But so we went from him kind of cracking a joke to long conversations, to him starting to reconnect with friends, eventually getting a job, girlfriend, started traveling, and really returning to kind of a full life. He had been an artist, a painter, and he returned to painting, and he actually displayed his art at the clinic, and you could see this amazing change in his art from before to after, even though for that period of time he didn't do any art for those years, but the artist that he was on the other side of this, it was pretty remarkable to see. So just an amazing story of the power of neurofeedback, neurostimulation to regulate dysregulation and have just profound effects on a person's ability to function and flourish.
So I'm going to share a couple of case studies with you as well. As I was listening to Guy talk about the two that he had, I always get overwhelmed with what Guy said, the power of neurotherapy to really change people's lives, not just reduce symptoms, but actually improve quality of life, which to me is way more important than getting rid of a few symptoms. So the first case study I want to talk about is, she's a 40-year-old female at the time she came in, a professional woman, a mom of 2 kids, very, very busy life. She came into our clinic about 1.5 years out from a motor vehicle head injury that had resulted in a TBI, and she had been doing work with a lot of different professionals, getting different services to help with the symptoms that she was having. So by the time she got to us, she had kind of exhausted a lot of what she was doing and still had these symptoms showing up. She would describe herself as just spacey all the time, which was not the norm for her. Lots of headache, moderate cognitive processing slowing. This was a big issue for her. It impacted her memory. It just impacted, word recall was a big thing for her, and started to have some impact on her sense of identity because it was impairing her abilities at work to some degree. She had difficulty with attention, she had motivation issues, had some mild panic episodes, and then a lot of just what she would describe as emotional sensitivity, where little things would just send her off and she couldn't seem to regulate in the way that she had always done. And so this was early on when we had first opened up the clinic too, and so our resources, we did not do neurostimulation back then, and so neurofeedback and heart rate variability were the direction we headed. But if you see on the screen here, her EEG findings, there were a lot of things that showed up. She had this excess lateralized slow activity in her temporal lobe, particularly in delta and theta. Guy had just mentioned that that's a common thing that we see. That lateralized, means oftentimes makes one wonder, did like one side of the brain get hit and it just, hit over on the brain inside the skull hit on the other side. She had a lot of spindling fast beta, 20 hertz was noticeable. This is kind of what you see in the image here, but she has it kind of across the board here. That oftentimes is a marker of TBI as well. It's in the C3, C4 area kind of, which is sort of in the temporal and central area. She had a lot of mirror neuron dysregulation showing up, excess slow activity, again, a common thing that we see. And she had this interesting pattern in her EEG where she had like these repeated, like if you watch her EEG, it would be just these repeated episodes of like wakefulness, and then she would be followed by stage 1 sleep, and then she'd come out and it'd be wakefulness again, and then there'd be another pattern of stage 1 sleep. And so that kind of that drowsiness, that slow wave activity kicking in, which is again kind of a common marker with TBI. So we did training with her, included our 19-channel neurofeedback, so we targeted some specific networks that were fairly dysregulated that showed up in the analysis. And then we did a good amount of heart rate variability to help her kind of begin to, she had a very dysregulated autonomic nervous system when we first started doing it. And by the time we had done, I would say, probably 6 or 7 handful of heart rate variability sessions, she was starting to note her ability to kind of manage that emotional sensitivity and that dysregulation that she had in emotions, and that was powerful for her because it had been impacting her in terms of her parenting, and for her to be able to kind of get back on track with that was really empowering for her. We also did audiovisual entrainment with her, so she was using an at-home device on a daily basis to address some of the symptoms that she had going on. As we went through training, the progress that she started to report was smoother word retrieval, which might not seem like a big deal, but for somebody who kind of identifies as a professional woman that's really cognitively on top of things, this was really kind of a game changer for her to have that start happening. And along with that came the improvement in her short-term memory, and that really kind of facilitated her starting to regain a sense of self again, like, oh yeah, this is me, as opposed to I just don't feel like me, which is how she talked when she first came in. Improved reading comprehension with nonfiction texts, again, very important. She, for a long period of time, just could not focus to read much of anything, but for her, the real test was nonfiction, because she couldn't kind of fill in the blank of the story as she was reading, like you can sometimes with fiction. And then her mood improved significantly. We did approximately 40, I think we did maybe a little bit more than 40 sessions with her, and she would, at the end of her training, said that she'd come in kind of thinking, well, I'm going to give this a try, I doubt this will work because here I am a year and a half out and still having these symptoms. And yet, when she left training, she felt like she was really back on track in terms of where she was at in her life in general. And then the second case study I want to talk about is a 12-year-old young woman, and she is a client that we are still working with in clinic, and she has had just kind of a fascinating history. So she came in when she started training, and we did her QEEG in November of 2023, and in September of that year, she had a concussion. She's a soccer player, and so she took a lot of hits to the head, and in September, she took one to the head that ended up being diagnosed as a concussion. And so when we did her QEEG initially, it showed up. And so Guy had talked about blue brain, and you can see kind of here in her EEG in November that she's really got a lot of that activity going on. Now, she had some of the symptoms that she came in with were pre-concussion. So this is an important piece of this young woman's story, is she had had some struggles from a very, very young age. The concussions, I think, exacerbated much of what was going on for her. So when she came in, the kinds of symptoms that she endorsed were anxiety, panic, depressed mood, emotion regulation difficulties, which were really impairing her in terms of her relationship with friends, but also within the family system. She had really sluggish cognitive tempo, executive function difficulties. Those things were showing up in struggles with school, in particular with being able to study and perform on exams. So we did her initial QEEG. We found what kind of is like blue brain of TBI. She also had some excess gamma in her insula, which likely was contributing to the emotion dysregulation. She was having some of the anxiety. She also had this interesting symptom of like obsessive internal focusing of thoughts, and there were a couple of things in particular that just would irritate her, just extremely irritate her, and then the emotion dysregulation would kick in, and it was just kind of a perfect storm for her to just kind of have struggles in terms of her relationships. You can see here, so she had a concussion when she came in. Then while we were training her, I got an email from mom in January saying she took another hit to the head and got diagnosed with concussion by the school professionals. And then, so we noted that, and we continued to do some work. And then in April, got another email from mom saying she took another hit, real hard hit to the head, and has been diagnosed with a concussion again. So it's not uncommon for that to happen, because when you have concussion, a lot of times some of that, your ability to kind of pay attention, to notice things in your environment can be impacted. And so people can oftentimes just end up not being as astute, and so I think that's likely part of what was happening with her. Maybe not all that, and there are other players involved with that too, and that could certainly be a component of it. So what we started doing with her was neurofeedback, and then eventually we moved to, once she got concussion number 3, I talked with mom and I said, maybe we should look at doing some photobiomodulation. So the family took a helmet home and started using it, and was finding it extremely helpful. So the progress she made along the way, and it was her parents were really, really good about being good historians of what was going on with her, and then reporting back to us about what they were seeing. So probably, I don't know, somewhere a third way through the training, I was corresponding with mom, and mom said she's happier, she's more relaxed, she tends to go with the flow a little bit better. And then probably about 3/4 of the way through her training, she started to do better socially. She started to be able to interact with friends in ways that didn't have all of that, like, wild emotional dysregulation going on. Which is interesting if you think about this, a 12-year-old, and so you might expect a 12-year-old girl to be, drama's just a thing, right? But she has gone the opposite direction and now is much better regulated in those relationships and can manage the dynamics of relationship much better. Doing better with her homework, which was a significant thing. She tended to do okay in school. She would get anxiety with test taking, but homework was a challenge, and that was impacting her school, and she's much more on track with that now. She used an audio-visual entrainment device. They started using this kind of at the beginning of training, and it had a pretty significant impact on her ability to focus, and I think that probably played a pretty significant role in her improvements with homework. And then Mom said she's a new person, she's happy, not anxious, less oppositional, and overall more confident. And then, so all of this seems really great, right? We've got this combination of treatments that is providing an opportunity for this young lady's brain to kind of redevelop in a way that is much more regulated. And so this report is just in and of itself just astounding. And for me, I can sleep well at night knowing that this young lady has had such improvement. So then today I got an email from her mom, and I just want to read a little bit of what her mom said. She says she's doing so incredibly well. She can be her true self now. It comes through somehow. She still has some intermittent concussion symptoms, and she's working, doing some vision therapy right now, in addition to continuing to do some work with us. And then her mom says, she said her concussion symptoms still persist intermittently, and she's kind of scared to go back to playing soccer. But the neurofeedback work we did leading up to the concussion must have been significant enough that she's continuing to improve and thrive emotionally. Her relationships with friends and family have dramatically shifted. It seems to be nothing short of a miracle. So what we know about this family, and what I know from the conversations I've had with the family, is the dysregulation that was happening in this young lady's brain was not only it negatively impacting her life, but the whole family system had been negatively impacted. The level of stress that they had was incredible. And it's pretty much changed now. They've got, Mom said to me a while ago, about a month ago, she said, we have our girl back. And that hasn't been the case since she was 2 years old. And so while not all of that is a result of, like, she had a traumatic brain injury and we cleared it up, clearly the TBI was having some kind of impact on her. And as you can see, we've begun to clear up some of her blue brain, right? And I think that's part of what we're seeing in terms of what Mom is reporting regarding progress with her. And again, this is like Guy was talking about this with the young man he was talking about. It's incredible to see somebody's life come back in that way. And so just a testimony to what neurotherapies can do. This is just some slides showing where she had some dysregulation, a lot of dysregulation in her temporal lobes that I think was impacting her school performance, as well as I think her anxiety. So I'm going to talk just a little bit about the services that we provide here. So we've kind of been talking about them as we've been sharing information about case studies and that sort of thing. So we provide in the clinic a variety of services that are in clinic, and then we also have a lot of at-home devices that we have clients utilizing. So neurofeedback is kind of the thing that people think about when they think about neurotherapy. Neurofeedback's a learning paradigm. We're working on the from kind of being rooted in operant conditioning and literally kind of training the brain to behave differently, creating new neural circuitry, and then really relying on the brain's neuroplasticity to continue that process long after people have left us. Neurostimulation, so this is transcranial electrical stimulation, pulsed electromagnetic stimulation, and can produce brainwave, help regulate brainwave functioning, reduces inflammation in the brain, increases oxygen flow to the brain, all of those things which for somebody with TBI, as you heard Guy talking about some of the damage that can occur, the neurostimulation can be a fantastic way to address that physiological damage. These are our audiovisual entrainment devices. These are at-home devices, although sometimes we have clients using them in clinic as well. But these devices are great for entraining the brain. They work really well. Lots of good research on using audiovisual entrainment to address symptoms of TBI. And what audiovisual entrainment is really doing is kind of getting, it's pulsating light and sound at particular brainwave frequencies, depending on what protocols you're programming in. And it's really kind of encouraging the brain to get in sync with it and start producing those frequencies on its own. So over time, with daily use of this, it can really strengthen those neural pathways that are being kind of cajoled into creation through the process of using the audiovisual entrainment. These devices are really great. You can see that the device here on the right here has these view-through glasses, and so those can be really nice. Somebody can be using them while they are doing something else, reading a book, just sitting and looking and having a conversation. That can be a really helpful product. And then Guy had mentioned earlier, we don't have a slide in here on the photobiomodulation, and I would be remiss if I did not mention that as one of the services that we provide. We have devices that we use, and for TBI, photobiomodulation is kind of like a no-brainer, pardon the pun, right? That it can be really, really beneficial in addressing that inflammation and the enhancing that mitochondria signaling. So that's kind of our presentation. This is just a slide that gives you some information about our process for if you're wanting to work with our clinic. Typically when we're working with somebody who is either has a TBI or is wondering about TBI, we're going to start with that assessment with the quantitative EEG, the evoked response potential. We do a report of findings that's pretty thorough, gives you over, 200 pages of images and data, and we give you a verbal report about those findings. And then typical training sessions in clinic on average are about 40 sessions. We like people to come in at least twice a week because what we're doing requires repetition to build up those neural circuitry or neural pathways. And so twice a week is kind of the minimum that we want you to come in. We do have people who come in more frequently than that, and that's certainly a fine thing to do. In some ways, maybe it would be more ideal. Thank you for your time and attention.